Test, test, test.
Test, test, test.
Okay, can everybody hear me? Let's see a yes or no in the chat box there. Can everybody hear me? Yes, good, good. Okay. Okay, does this sound smooth? No scratchiness this time, hopefully? See an answer in the chat box, please. Does this sound smooth and no scratchiness? Okay, that's good. And I apologize for the late notice for being early. I sent out that email last week saying it was going to be for several weeks, maybe a few months. It's going to be on Tuesday or Wednesday instead of Thursday. And I just had a conflict with that. And I apologize for that, but just couldn't avoid it. So we're going to jump right in here. Okay. Internuncial neurons. Secondary hyperalgesia associated with deep or superficial injury causes increased excitability in the network of internuncial neurons, which receives convergent noxious impulses from cutaneous and deep somatic or cutaneous and deep visceral tissue structures. Injury to skin produces hyperalgesia, and as a result, nerve endings become hyperexcitable, consequently barraging the dorsal horn with noxious impulses that sensitize the dorsal horns to such an extent that they would be excited by subliminal stimuli. So things that you normally wouldn't even feel will cause pain. And this, you're going to see how this is very, very important later on. And I want to emphasize here also the next class that we have is going to be on areolar tissue, and that is not nipple tissue. That's something that you probably have never heard of, but it's going to be quite tied in with this one. So make sure you don't miss the next one either. Secondary hyperalgesia, which is allodynia, pain caused by non-noxious stimulus to normal skin that does not normally provoke pain, is caused by sensitization of wide dynamic range neurons in the dorsal horn. Now, I understood allodynia just to be pain before. When I was first introduced to that word. How many of you know that allodynia before right now was pain caused by noxious stimuli to skin that doesn't normally provoke pain? How many of you knew that already? So when I was first introduced to the word allodynia, it was just pain, period. Let's see a response here in the chat box. How many of you knew that? No takers this time? Come on, we need a little bit of feedback in here. Okay, here we go. Okay, changes take place in the spinal cord and primary afferent and spinal neurons that can produce such changes in nociceptive responses, collectively termed central sensitization. So now we're getting into the central nervous system, which may last many minutes to hours after repeated afferent input ceases or is blocked. So now we're making changes in the central nervous system that causes later type of pain. This also applies to chronic pain models, inflammation due to tissue injury and neuropathy from damage to nerves, the interaction between the immune and nervous systems. This makes a somewhat arbitrary distinction in that immune cells can mediate nerve damage and nerve damage may activate immune cells. So here's your neuroimmune system, which may be active in this whole situation. Inflammatory agents given on the skin, such as acetic acid from vinegar, carrageenan, a substance extracted from red and purple seaweeds consisting of a mixture of polysaccharides, uses thickening or emulsifying agent in food products, capsaicin, which is hot peppers or spicy foods, for example, formalin, basically formaldehyde found in clothes, carpet, drapes, furniture, etc., and mustard oil. This is found in all cruciferous vegetables, cabbage family, mustard family. So any of these that you're exposed to can cause this. And so basically you have to look at these chemicals that you're exposed to, everyday chemicals that can make you very susceptible to subliminal things that are just causing pain that normally wouldn't at all. And they all have been given on the skin or viscera to produce pain responses or facilitations in pain responses, developing within seconds to days. Okay, now how many of you knew that any of these, like vinegar, carrageenan, which is polysaccharide in food, capsaicin, found in everything, including food, mustard oil, and just formaldehyde on furniture, carpet, drapes, and in clothes can cause pain within seconds that lasts. How many of you knew that? Let's see that in the box over at the right here. How many of you knew that? Oh, we have somebody who did know it. That's good. So basically, somebody who gets new clothes or new furniture, they might start having skin responses, painful. People who are exposed to vinegar in their hand, in their mouth, capsaicin, certain types of polysaccharides like carrageenan, mustard oil family foods, can start having all sorts of pain just from exposure to skin or epithelial structures. Now, those are things that you just need to start looking for. These result in ongoing withdrawal patterns in the central nerve's sensitization from ongoing peripheral mechanisms, contributing to pain behaviors from initiation of several second messengers, causing the lingering effects and leading to patients learning to hurt. So these can be lasting over a long period of time. Healthy individuals generally don't perceive light digital pressure stimulus to be painful. Therefore, this finding in fibromyalgia syndrome, or FMS, seems to represent a lower than normal pain threshold and meets the clinical definition of allodynia. So fibromyalgia syndrome meets the definition of allodynia. For that reason, it was proposed that fibromyalgia could be viewed mechanistically as chronic widespread allodynia. How many of you knew that fibromyalgia syndrome is also termed chronic widespread allodynia? How many of you knew that? Let's see that in the box over to the right. How many of you knew that fibromyalgia syndrome is also referred to as chronic widespread allodynia? Okay, we have one person that did. Come on, let's have some feedback in here. No. No? Okay. Okay, so we're learning something. 2 studies conducted in Canada and the United States found that approximately 65% of the general population are free of pain at any given time. 5% transient pain, 20% regional, 10% have widespread pain. Now this is interesting. Chiropractors see about 17% of the population annually. Hey, that's half of the pain patients right there. How many of you knew that chiropractors saw half of people experiencing pain every year? Let's see that in the box over there. How many of you knew that chiropractors see half the patients in the United States that are experiencing pain? Let's see that in the answer box over here. So this is quite higher than the figures that we're told about. All we're told about is, oh, we only see 17% of the population. Well, that's half of the pain population. And it's actually more than half of those that have kind of constant pain, okay, because 5% of those are transient. And we've also seen about 75% of the whole population in the United States at some point in their lives. How many of you knew that? Let's see that in the answer box. Chiropractors have seen about 75% of the whole population of the United States at some point in their lives. Let's see the answer to that. How many of you knew that over there? This is quite higher than what our leaders would have us know, okay? And so that's quite a different figure there. 2% of the general population have fibromyalgia syndrome sufficient to meet American College of Rheumatology criteria. So 6 to 10% of patients in a typical physician's waiting room meet the criteria for fibromyalgia syndrome, about 1 in 10. So that means roughly about 2 in 10, maybe, of the patients that we see classify as chronic fibromyalgia syndrome, okay? Gross anatomy gives little indication of the functions of the central nervous system beyond those inferred from the peripheral connections of the various nerves. This is right out of guess what? Gray's Anatomy. So Gray's Anatomy admits that, hey, the nervous system really doesn't tell us a whole lot about the central nervous system. How about that? Knowledge of functional significance of the various parts of the system based on their structure can only be obtained with any certainty from a study of the connections of the groups of cells, but no complete picture of the connections of the cells in the nervous system is available. The anatomical approach to the study of its function cannot yet produce more than a very sketchy outline. Wow. So even Gray's Anatomy says that all we have is a very sketchy outline of the connections of function of cells. Wow, how about that? The nervous system. The divisions of the central nervous system based on gross anatomy represents parts of a unit concerned with integrating the activity of every part of the body. Integrating the activity of every part of the body. This system requires a high degree of integration of its parts attained by nerve fibers connecting the various regions of the central nervous system reciprocally. The central nervous system consists of 3 types of cells: sensory, connector or internuncial, and motor. Sensory neurons have 2 processes, one of which passes to a sensory ending, the cell lying outside the CNS, either in the spinal ganglion of a dorsal root or in corresponding ganglia of cranial nerves adjacent to the brain, the retina, the olfactory or mucous membrane. The other process enters central nervous system, extends for a variable distance, giving rise to a number of branches throughout which it can activate several internuncial neurons. Internuncial neurons are imposed between the sensory and motor cells and are not directly connected to either with the sensory ending or with an effector organ. They comprise almost all the gray matter of the CNS. How many of you knew that internuncial neurons is basically what all the gray matter is in the central nervous system. How many of you knew that? Let's see an answer in the chat box here. We have a couple of yeses here. Now, normally what we were taught in school is the internuncial neuron connects one side of the body to the other. In other words, the same nerve going to this limb to perform a function goes to the other limb, and there's an internuncial or interneuron between those. But we really weren't taught that it's the whole gray matter of the central nervous system. It includes the cerebrum, cerebellum, thalamus, corpus striatum, many small nuclei, more scattered groups of nerve cells. They lie entirely within the CNS, excepting the preganglionic cells of the autonomic nervous system, sending axons to the peripheral autonomic ganglia consisting of motor cells. Now the motors, notice, is highlighted here. We're going to more about that later. They form the pathways through which impulses pass for production of local reflexes and link together the parts of the central nervous system. At all levels of the CNS and local and distant connections, they act together in constantly changing patterns, depending mainly on the varying sensory impulses entering the nervous system. So they have no action without the sensory impulses entering the sensory nervous system. Their interactions result in free passage of impulses through certain nervous pathways, while other pathways are blocked or inhibited, so inappropriate reactions don't take place. The continuous interplay of facilitation and inhibition within the complex network of internuncial neurons eventually affects motor cells to produce overt reactions, such as muscular contraction or inhibition, vasoconstriction or dilatation, glandular secretion or inhibition, etc. They interrelate the vast number of sensory impulses pouring into the nervous system over a wide area, transmitting the sensory information to every part of the nervous system, essential part of any integrating system. Only certain sensory regions seem to be capable of evoking subjective awareness of sensation in man, the cerebral cortex. So there are only certain ones that we consciously perceive. Axons of internuncial neurons from tracts and bundles conveying impulses headward to the sensory regions from the spinal medulla and brainstem are frequently called sensory tracts, though they differ from similar fibers carrying the same information to other regions like the cerebellum, in that their destruction interferes with the conscious awareness of certain sensations. So basically it interferes with the conscious awareness in a lot of cases. All the various regions of the CNS are connected with those lying caudal to them, and as such descending connections produce effects on the caudal parts of the nervous system, similar to the effects of the ascending connections on the more cranial parts. However, since all motor cells lie in the brainstem and spinal medulla, activity in descending pathways like the cerebral cortex often results in production of a movement or other activity which can be readily observed, for which reason the descending pathways and cells which give rise to them are frequently called motor. However, ascending pathways connecting various segments of the spinal medulla with each other or with the brainstem may equally produce motor effects through motor cells at those levels. So the interconnections between the brains are also motor, even though we don't sense those per se. And we don't click with those. Any movement produced by activity in internuncial neurons at the same or a different level of the CNS calls for inhibition of local activity at variance with the movement which the motor pathway is producing, in addition to the inhibition of the antagonistic muscles. The motor pathways composed of internuncial neurons are therefore of necessity also inhibitory in their actions, so they produce and inhibit actions. The terms sensory and motor must therefore be applied with caution to the pathways composed of axons of internuncial neurons since they are not equivalent to the same terms applied to nerve cells attached to either sensory endings or true sensory neurons, or to the effector organs, true motor neurons. Sensory information from the receptors of the entire body surface and from some deep structures enters the central nervous system through the peripheral nerves and is conducted to multiple sensory areas. Signals are then relayed to essentially all other parts of the nervous system. So everything in the nervous system knows what everything else is doing, and it has to be that way. You couldn't stand or move without it being that way. The most important ultimate role of the nervous system is to control the various bodily activities. This is achieved by controlling contraction of skeletal muscles, contraction of smooth muscles in the internal organs, secretion by both exocrine and endocrine glands, collectively called motor functions of the nervous system. They're called effectors because they perform the functions dictated by the nerve signals. The major function of the nervous system is to process incoming information in such a way that appropriate motor responses occur. Now, let's just take a look at that, because we're told in chiropractic above, down, inside, out, but that basically deals with consciousness, and a lot of this stuff is subconscious. And just think of it, if a baby is born out of amniotic fluid into a sensory deprivation chamber, how much would the nervous system develop? Basically nothing at all, because there's no sensory input. Therefore, there's no motor responses in reaction to the sensory input. Just the opposite of what we were taught in school. Position sensory receptors. Knowledge of position, both static and dynamic, depends on knowing the degrees of angulation of all joints in all planes and their rates of change. Therefore, multiple different types of receptors help to determine joint angulation and are used together for position sense. Both skin tactile receptors and deep receptors near the joints are used. So you have the angulation of all joints rely on skin tactile receptors too. It's not just the joints. In the case of the fingers, where skin receptors are in great abundance, as much as half of the position recognition is believed to be detected through the skin receptors. For most of the larger joints of the body, deep receptors are more important. I would take exception with that, dealing with what we deal in T-TAPs, because we see that just light stimulation to the skin controls the joints, which you'll see here. After the important sensory information has been selected, it's then channeled into proper motor regions of the brain to cause the desired responses, called the integrative function of the nervous system. Thus, if a person places a hand on a hot stove, the desired response is to lift the hand, or the flexion reflex, and other associated responses such as moving the entire body away from the stove. The storage of information is the process we call memory, a function of the synapses. Each time certain types of sensory signals pass through sequences of synapses, these synapses become more capable of transmitting the same signals the next time, called facilitation. It's also called the Hebs reflex too. After the sensory signals have passed through the synapses a large number of times, the synapses become so facilitated that signals generated within the brain itself can also cause transmission of impulses through the same sequences of synapses, even though the sensory input has not been excited. So basically, the facilitation occurs in the brain, and the brain transmits the same sequences over and over. This gives the person a perception of experiencing the original sensation, although in effect they are only memories of the sensations. So, big question is, why does somebody still experience symptoms 5, 10, 20, 30, 40, 50, 60 years after an incident, even though they were healed probably totally maybe a year after the incident? Well, the thing is it's relapsing through the central nervous system. Therefore, I would submit to you, for us to correct the symptoms, we have to erase the memory of the pain. We have to erase the memory of the injury from the brain. Okay? That's the only way we can do that. It's right there. It's right there. Non-adapting nature of pain receptors. In contrast to most other sensory receptors of the body, pain receptors adapt very little, sometimes not at all, because it allows them to keep the person apprised of a damaging stimulus that caused the pain as long as it persists. Inhibition of pain transmission by tactile sensory signals. Look at this. Inhibition of pain transmission by tactile sensory signals. So, tactile skin can inhibit pain. Large type AB sensory fibers from the peripheral tactile receptors can depress the transmission of pain signals, resulting from a type of local lateral inhibition. The spinal cord is a conduit for signals from the periphery of the body to the brain or in the opposite direction. Neuronal circuits in the cord can cause walking movements, reflexes that withdraw portions of the body from painful objects, reflexes that stiffen the legs that support the body against gravity, like standing and sitting, reflexes that control local blood vessels, like high and low blood pressure, gastrointestinal movements, and so forth, in addition to many other functions. So all that stuff goes through the spinal cord. And this is what I show people directly out of Guyton's 9th edition when they tell me that their medical doctor or their nurse says that chiropractors are quacks. I open it up and I have them read it out loud. They say, wow, why didn't they know that? I tell them, I don't know. This is a medical textbook and they have it just like I do. It's what we all learn out of. Many functions of the nervous system, such as the process of memory, requires prolonged changes in neurons for seconds to months after the initial transmitter substance is gone. The ion channels are not suitable for causing prolonged postsynaptic neuronal changes because these channels close within milliseconds after the transmitter substance is no longer present. That's pretty quick. In many instances, prolonged neuronal action is achieved by activating a second messenger chemical system inside the postsynaptic neuronal cell itself, and then the second messenger causes the prolonged effect. So when I get somebody that another doctor or therapist has been struggling with maybe for decades, I send them back there, and they inevitably call me up and say, how'd you do it? I said, well, I stimulated the large type AB sensory fibers to shut off the second messenger, the central nervous system. And it's causing a prolonged effect. And wow, you start getting referrals because you're talking their language, okay? Mechanoreceptors detect mechanical deformation. Nociceptors detect damage occurring in the tissues. Now, note this. Pain receptors in the skin are almost never stimulated by usual touch or pressure stimuli, but do become highly active the moment tactile stimuli become severe enough to damage the tissue. If pain fiber is stimulated, the person perceives pain, regardless of what type of stimulus excites the fiber. Likewise, if a touch fiber is stimulated by exciting a touch receptor in any way, the person perceives touch because the touch fibers lead to specific touch areas in the brain. So here we're going right by with touch to the allodynia centers in the brain. All sensory receptors have one feature in common. Whatever the type of stimulus that excites the receptor, its immediate effect is change of the membrane potential of the receptor. This change in potential is called a receptor potential. Mechanical deformation of the receptor stretches the receptor membrane and opens the ion channels. The Pacinian corpuscle has a central nerve fiber extending through its core. Surrounding this are multiple concentric capsule layers so that compression anywhere on the outside of the corpuscle will elongate, indent, or otherwise deform the central fiber. So this is a Pacinian. Now we're going to get into the others here in a minute. Mechanism by which a receptor potential is produced in the Pacinian corpuscle. Small area of the terminal fiber that has been deformed by compression of the corpuscle Note that ion channels have opened in the membrane, allowing positively charged sodium ions to diffuse to the interior of the fiber. This creates positivity inside the fiber, which is a receptor potential. Receptor potential in turn induces a local circuit current flow that spreads along the nerve fiber. The local current flow depolarizes the fiber membrane at the node. This then sets off typical action potentials that are transmitted along the nerve fiber toward the central nervous system. So we're doing all this by touch. And so you have a physical opening of a pore. The sodium ion goes inside and it causes a physiological response. Receptors called rate receptors, movement of receptors or phasic receptors in the case of Pacinian corpuscle, sudden pressure applied to the tissue excites this receptor. And Pacinian corpuscle is important in apprising the nervous system of rapid tissue deformations. Okay, so it's a sudden pressure, rapid tissue deformations. More about that in a minute. Positive stretch reflex. The simplest manifestation of muscle spindle function is the muscle stretch reflex, also called myotatic reflex or muscle spindle stretch reflex. That is, whenever a muscle spindle is stretched, and that's quickly, just like a reflex hammer, excitation to the spindles causes reflex contraction of the large skeletal muscle fibers of the same muscle and closely allied synergistic muscles. You can do this in the intrafusial or the extrafusial fibers, so the Golgi tendon organs respond in the same way. Stretch reflex can be divided into two components. The dynamic stretch reflex is elicited by the potent dynamic signal transmitted from the primary endings of the muscle spindles caused by rapid stretch of the muscle. That is, when a muscle is suddenly stretched, like a reflex hammer, strong signal is transmitted to the spinal cord. This causes an instantaneous strong reflex contraction of the same muscle from which the signal originated. Thus, the reflex functions to oppose sudden changes in the length of the muscle because muscle contraction opposes the stretch. The dynamic stretch reflex is over within a fraction of a second after the muscle has been stretched to its new length, so it's very, very quick. But then a weaker static stretch reflex continues for a prolonged period thereafter. It continues to cause muscle contraction as long as the muscle is maintained at an extensive length. Muscle contraction in turn opposes the force that causes the excess length. Negative stretch reflex. When a muscle is suddenly shortened, exactly opposite effects occur because of decreased nerve impulses from the spindles. If the muscle is already taut, any sudden release of the load on the muscle that allows it to shorten will elicit both dynamic and static reflex muscle inhibition rather than reflex excitation. Thus, this negative stretch reflex opposes the shortening of the muscle in the same way that the positive stretch reflex opposes the lengthening of the muscle. Therefore, one can begin to see that the stretch reflex tends to maintain the status quo for the length of the muscle, or normal tonus. Flexor reflex and the withdrawal reflexes. Cutaneous sensory stimulus on a limb is likely to cause the flexor muscles of the limb to contract, therefore withdrawing the limb from the stimulating object, the flexor reflex. In its classic form, the flexor reflex is elicited most powerfully by stimulation of pain endings, such as by a pinprick or heat, for which reason it's called a nociceptive reflex, or simply a pain reflex. Stimulation of the touch receptors can also elicit a weaker and usually less prolonged flexor reflex. Now we're getting into allodynia, but you don't even need allodynia. You just need a light touch. We talk about that somewhat in part 1 and the beginning of part 2, where we correct all the weak muscles in the body just with touch by stimulating those nociceptors just with touch, and also getting rid of palpatory pain, i.e. Trigger points in the muscles just with touch also, And again, it's just by stimulating the regular nociceptors just with a touch, but not on a painful spot. If some part of the body besides one of the limbs is painfully stimulated, this part in a similar manner will be withdrawn from the stimulus, but the reflex may not be confined to flexor muscles, even though it's basically the type of reflex. Therefore, the many patterns of reflexes of this type in different areas of the body are all called withdrawal reflexes. So you got a whole lot of patterns of the withdrawal reflexes. The pathways for eliciting the flexor reflex do not pass directly to the anterior motor neurons, but instead pass first into the interneuron pool. So here we're at the interneurons again. Interneuron pool of neurons, only secondarily to the motor neurons, diverging circuits to spread the reflex to the necessary muscles for withdrawal, circuits to inhibit the antagonist muscles called reciprocal inhibition circuits, circuits to cause a prolonged repetitive after discharge even after the stimulus is over. So all of these withdrawal reflexes occur because of the action of the interneuron pool of neurons, or internuncial pool of neurons. Pattern of withdrawal. During this time, other reflexes and actions of the central nervous system can move the entire body away from the painful stimulus. The pattern of withdrawal that results when the flexor reflex and other types of withdrawal reflexes is elicited depends on the sensory nerve that is stimulated. Thus, a painful stimulus on the inside of the arm not only elicits a flexor reflex in the arm, but also contracts the abductor muscles to pull that can most effectively remove the pain part of the body from the object that caused the pain. The same principle, called the principle of local sign, applies to any part of the body, but especially to the limbs because they have highly developed reflexes. So basically you get stuck in withdrawal, and that's what causes chronic contortions and chronic problems. Cross-extensor reflex. Look at how quick that happens after the flexor. About 0.2 to 0.5 seconds after a stimulus elicits a flexor reflex in one limb, the opposite limb begins to extend. This is called the cross-extensor reflex. Extension of the opposite limb can push the entire body away from the object, causing the painful stimulus in the withdrawn limb. It is certain that many interneurons, this is another name for internuncial neurons, are involved in the circuit between the incoming sensory neuron and the motor neurons of the opposite side of the cord, responsible for the cross extension. Furthermore, after the painful stimulus is removed, the cross-extensor reflex continues for an even longer period of after discharge than that for the flexor reflex. The prolonged after discharge would be a benefit in holding the body away from a painful object until other nervous system reactions could cause the body to move away. Reciprocal inhibition and reciprocal innervation. Excitation of one group of muscles is usually associated with inhibition of another group. For instance, when a stretch reflex excites one muscle, it often at the same time inhibits the antagonistic muscles. Has to. This is the phenomenon of reciprocal inhibition, and the neuronal circuit that causes this reciprocal relation is called reciprocal innervation. Likewise, the reciprocal relations often exist between the two sides of the cord, as exemplified by the flexor and extensor reflexes described above. So when you have both sides either relaxing or contracting at the same time, that's because the interneurons are off and this reciprocal innervation is off. Reflexes of posture and locomotion. Pressure on the foot pad causes the limb to extend against the pressure being applied to the foot. This reflex is called a positive support reaction. It involves a complex circuit in the interneurons, similar to those responsible for the flexor and extensor reflexes. Locus of the pressure on the pad of the foot determines the direction in which the limb will extend. Pressure on one side causes extension in that direction, the effect called the magnetic reaction. For example, this keeps an animal from falling to that side. So you can basically find where the pain is on the foot, on the bottom of the foot, and figure out why a person is walking or running abnormally. If it's coming from the sensory neurons in the bottom of the foot, which causes an abnormal signal through the interneurons, an abnormal posture, an abnormal gait. Laid on its side, will make movements that indicate trying to raise to the standing position. This is called the cord riding reflex. Such a reflex demonstrates that relatively complex reflexes associated with posture are integrated in the spinal cord. And again, it's the internuncial neurons that integrate these things in the spinal cord. Oscillation back and forth between the flexor and extensor muscles seems to result mainly from mutually reciprocal inhibition circuits that oscillate between the neurons controlling agonist and antagonistic muscles within the matrix of the cord itself. Sensory signals from the foot pads from the position sensors around the joints play a strong role in controlling foot pressure and rate of stepping. And the foot is allowed to walk along a surface, and in fact the cord mechanism for control of stepping can still be more complex. For instance, if during the forward thrust of the foot the top of the foot encounters an obstruction, the forward thrust will stop temporarily, but then in rapid sequence the foot will be lifted higher, proceed forward to be placed in the obstruction. This is the stumble reflex. Thus, the cord is an intelligent walking controller. So when somebody looks like they're tripping all the time, it's stuck in the stumble reflex. And that may be from something that's going on the top of the foot where it hit, and so the body always thinks that it's stumbling. So they look like they're tripping every time that they step. And so they have not normal gait, like one is shortened and one is quick, and the other one is normal, okay? And so you got to look at the top of the foot for that particular one. Every time stepping occurs in the forward direction in one limb, the opposite limb ordinarily steps backwards. This effect results from reciprocal innervation between the two limbs. So reciprocal innervation occurs between the muscles on one side, between the limbs from side to side, also the arms and the legs. All that gait is reciprocal innervation. In general, stepping occurs diagonally between the forelimbs and the hind limbs. Such a walking pattern is called the marked time reflex. It's called cross crawl in applied kinesiology. The rest of the world calls it marked time reflex. Muscle reflex that may further stimulate the sympathetic nervous system, aside from the sympathetic stimulation caused by direct signals from the brain. Reflex signals from the contracting muscles pass up the cord to the vasomotor center and excite the sympathetic nerve still further. These signals are initiated by metabolic end products acting on small sensory nerve endings in the muscle tissue. So when you're standing and walking, basically the heart is only responsible when you're standing for about 40% of the pumping of the blood. Muscular action here stimulating the sympathetic nerves and vasoconstriction and dilation is responsible for 60%. This is the action. Vestibular postural reflexes. Sudden changes in orientation of an animal in space elicit vestibular reflexes that help to maintain equilibrium and posture. For instance, if an animal is suddenly pushed to the right, even before it can fall more than a few degrees, its right leg extends instantaneously. That's that magnetic reaction. Another type of vestibular postural reflex occurs when the animal suddenly falls forward. This occurs when the forelegs extend forward, the extensor muscles tighten, muscles in the back of the neck stiffen to prevent the animal's head from striking the ground. When you fall backwards, it's just the opposite. Vestibular mechanism for stabilizing the eyes. When a person changes direction of movement rapidly or even leans the head sideways, forward or backward, it would be impossible to maintain a stable image on the retina of the eyes unless the person had some automatic control mechanism to stabilize the direction of gaze from the eyes. Each time the head is suddenly rotated, signals from the semicircular ducts cause the eyes to rotate in a direction equal and opposite to the rotation of the head. So basically, balance between the semicircular, the canals, the neck, and the eyes occurs for vestibular mechanism for stabilizing. Neck proprioceptors. The vestibular apparatus detects the orientation and movements only of the head. Therefore, it's essential that the nervous centers also receive appropriate information depicting the orientation of the head with respect to the body. This information is transmitted from the proprioceptors, the neck, and the body directly to the vestibular and reticular nuclei of the brainstem and indirectly by the way of the cerebellum. Among the most important proprioceptive information needed for maintenance of equilibrium is that transmitted by the joint receptors of the neck. When the head is leaned in one direction, bending the neck impulses from the neck proprioceptors keep the vestibular apparatus from giving the person a sense of mal-equilibrium. Signals that exactly oppose the signals transmitted from the vestibular apparatus. And however, when the entire body leans in one direction, the impulses from the vestibular apparatus are not opposed by signals from the neck. The importance of visual information in the maintenance of equilibrium. Proprioceptive information from other parts of the body besides the neck is also important in the maintenance of equilibrium. Pressure sensation from the foot pads, for example, tell where the weight is distributed equally between the 2 feet and the weight is more forward or backward on the feet. Now, in this discussion, I would tell you that I think a whole lot of people have these sensory distributions off in the feet because most people basically have their pressure forward on the foot or back on the heels or more to one side than the other side. So I think there's a whole lot of damage in the bottom of the feet that's causing a lot of problems from there up, and it's from the sensory areas of the skin on the bottom of the foot and the foot pads. Now, man walks in an upright position and his limbs have become straightened to the point that almost no muscular strength is required to maintain the weight of the body against gravity. For instance, the direct line between the center of mass of the body and the direction of the gravitational pull runs slightly behind the axes of the hip joints, so that gravity tends to extend the hips, and so that the ligaments of the hip joints rather than the muscles support the body against gravity. So the ligaments of the hip joints are very, very pivotal in maintaining an upright position when in standing in humans. The stretch reflex is considered essential in maintaining muscle tonus, can produce increased tension of certain muscle groups so as to provide a background of postural muscle tonus against which voluntary movements can occur. Most reflex arcs include at least one internuncial neuron between the afferent and efferent fibers. The stretch reflex has no such internuncial or intermediary neuron, and the efferent neuron makes a direct contact with the efferent neuron across the single synapse in the spinal cord. Now, that being said, every time that you do something in one area of the body, the rest of the body knows about it, and that's how you keep your balance. So even though it says that, and even though this is what's believed, I don't believe that's the whole story. I think there's always internuncial neurons because nothing happens in one area of the body without some other area of the body being involved with it. Stretching the muscle stimulates its spindles. Afferent nerve fibers from muscle spindles enter the spinal cord through the dorsal root nerves and go anterior through the gray matter. There's the gray matter again, the internuncial neurons, to the spinal cord to reach the anterior horn where synapses with motor cells are made. Higher supraspinal centers are believed to send impulses to skeletal muscle by 2 routes, one of them involving large alpha motor neuron cells, the other small gamma motor neurons. The gamma neuron may be stimulated by afferent dorsal root fibers coming from the muscle spindles so as to cause contraction of intrafusal fibers via a stretch reflex. Oh, wait a minute. It just said that the stretch reflex did not go anywhere, okay? But this says it goes through the gray matter to the spinal cord. It just contradicted itself. Okay. So main muscle mass, so the gamma innervation may serve as a starter for alpha motor neurons. Proprioceptors. There are two main types of proprioceptors in joint capsules: Ruffini or end organ corpuscles and Pacinian. Ruffini end organs appear to be mainly responsive to tension. Pacinian appear to be responsive to compression. Proprioceptors in skin are similar to those found in joint capsules. Tension in skin can be caused by movement in a number of different directions, and proprioceptors may make a significant contribution to joint stabilization and reflexive muscular activity. So here we have skin affecting the joints and everything around the joint. This is basically Hilton's law of physiology. Now, we were taught as chiropractors everything comes out of the joints and the nerves from the joints, but here it says that the joints react to the tension and movement of the skin. Okay? Skin proprioceptors, including Meissner's corpuscles, are located superficially in the skin, respond rapidly to transient movements of the skin. Pacinian corpuscles are found deeper in the subdermal layer of the skin. So we here have Meissner's superficial, Pacinian the deep subdermal layer of the skin. For Pacinian, corpuscles respond quickly to high-frequency transient movements of the skin, and it's believed that these mechanoreceptors connect to the cortex and modify activity of the limbs. So here we have Meissner and Pacini and Ruffini modify the activity of the limbs. Joint and skin receptors also facilitate the vestibular apparatus to stabilize the extremities during gait by stimulating the necessary muscles to contract more forcefully and efficiently. So here, the receptors in the skin are controlling the muscles, which then control the joints. Wow, that's just kind of the opposite of what we learned. Skin proprioceptors identify environmental changes and provide information about your body's postural alignment. Ruffini corpuscles are oriented with their long axes parallel to the surface of the skin and are most sensitive to skin stretch. So all of them respond to stretch. Superficial, intermediate, and deep in the skin. Stretches the collagen fibers within the Ruffini corpuscle, which compresses the axon terminals. As the collagen fibers remain stretched and the axon terminals remain compressed during the skin stretch, the Ruffini corpuscle's primary afferent axon produces sustained, slowly adapting discharge to maintain the stimuli. Ruffini corpuscles in skin are considered to be skin stretch sensitive receptors of this discriminative touch system. They also work with proprioceptors in the joints. So the receptors in the joints work with the receptors in the skin. Therefore, as we stated in a previous class, you adjust the joints, you're affecting the skin. And as we learn in other classes, you affect the skin, you affect the joints and all the muscles around it. And the muscles to indicate the position and movement of body parts. Ruffini endings are located in the deep layers of the skin, register mechanical deformation within joints, more specifically angle change, with a specificity of up to 2 degrees, as well as continuous pressure states. They also act as thermoreceptors, respond for a long time, so in case of a deep burn, there will be no pain as these receptors will be burned off. Skin stimulation changes muscle tone and joint angulation, to summarize it. Okay, so basically we're looking at interneurons are affected basically by stimuli that they get from the outside. And, we could go on and on and on further because it involves the whole nervous system. But for our purposes, we're looking at skin, we're looking at allodynia, we're looking at prolonged reactions in the central nervous system. And because of that, you have memory of pain, memory of injury that we have to erase in order to get rid of. We have to erase it in the central nervous system. We have to erase the memory of it to get rid of the pain and numbness and tingling and different things from these aged type of conditions. But we have to go through the interneurons to get to the central nervous system, to get to the brain, to erase the memory of it. Okay? And so we've taken a long route around to show you all this. Now, of course, the white matter covers the gray matter. And that's something for a different topic. Okay, does anybody have any questions whatsoever about allodynia, about internuncial neurons, interneurons, about any of the receptors involved? Any questions whatsoever? Now's the time to ask them. Okay, we're going to move to the next topic. Now, all of us have heard about evidence-based medicine and best practices. And this document is basically, I copied it directly out of ACA, their website. And most of us bat this around. We're expected to follow it, but they never tell us what it is. And when I first applied for PACE, the guy, I make a statement on everything that, all my seminars that I produce, that it goes by evidence-based medicine best practices as put out by the ACA. And he says, I was on the ACA's, board, and I don't even know what they are. And I sent this back, and I said, well, you should have read the website because it's right there. Even the guy on the board of the ACA didn't know the definitions, okay? So I'm telling you, please copy these off. And you can press a button and get those from me. You can send me an email. I'm going to type the email out here for you if you wish. And that's drbbbrk@hotmail.com. You can call me if you ever need something, 469-995-9907. If you need help with any patients at any time, don't hesitate to call me. That's what I'm here for. You should have this, basically best practices and evidence-based medicine. What it is evidence-based medicine is they've done the studies in the major journals. They've been peer-reviewed. That's evidence-based medicine. Best practices is you've had experiences in your own practice. And they include both of those. So I would urge you to get this and read through it because this is endorsed by not only the ACA, but the British Medical Journal. Okay? Hold on just a minute. I'm trying to find something here. There we go. Okay. Okay. All 4 videos are out for all TTAP's parts. And basically they're in post-production, so they're $500 for a year's viewing. But since you're on this call, if you order them right away by tomorrow, you can get them for $250, and I will extend that courtesy to you. Now, you can call me at 469-995-9907 or go online to my website, ttapcenter.com. Click Seminars Professional. Go to the seminar you want, 1, 2, 3, or 4. Type under requested location film and your phone number. That tells me you want the film. Click the down arrow by $395 and choose the $250 option. And I will get those right out to you. You can pay online or you can just simply call me. Now, what are they about? Part 1, use of myotatic reflexes. You notice that stretch reflex. Well, I came up with a lot of things that dealt directly with the stretch reflex, and it's explicit throughout reflexes in the medical literature. I quote a lot of them, and we've come up with technique based on those. And in this particular seminar, we show you that you don't need the deep to work on deep scar tissue and the tissue outside of the joints for every condition, like ART and Graston transverse friction massage says. You don't need to do really deep like Nemo says in the receptor tonus and trigger points. These are really light, and we also show that you have light scar tissue on the skin that can address a lot of things very quickly and easily. For example, you can get someone off a cane or a walker in 1 or 2 visits, standing up out of a wheelchair in a few visits if it's due to weakness instead of paralysis. And we've done this on people at seminars. Immediately restore a significant range of motion. Understand how reciprocal innervation can immediately help restore function in distant parts of the body. Correct foot drop in the majority of cases, 1 or 2 visits. Cogwheel rigidity of arm and leg, most stroke victims and cerebral palsy victims, and that's pretty immediate. Improve hearing and tinnitus in most cases pretty quickly. This fulfills the AC evidence-based medicine and best practices. For example, some of the things that we teach: fibromyalgia pain, sciatica. This is you use Lasag's, and it's verifiable. All of these are verifiable on normal orthopedic and neurologic exams. A herniated or bulging disc from Milgram's, unoperated rotator cuff, frozen shoulder, regional pain syndrome, formerly called reflex sympathetic dystrophy, burning tongue and mouth syndrome, burning pain in lower extremities or genitals and upper body, female cyclical menstrual pain, vaginal prolapse, numb hands and feet, cranial nerve symptoms, loss of hearing of different frequencies, tinnitus, foot drop, outlet syndromes, or tunnel syndromes, cold and burning hands or feet, Raynaud syndrome, loss of vibration sense in the feet or toes, dizziness and vertigo, positive pinwheel test, bladder leakage, vaginal prolapse, numb hands and feet, drop transverse cuboid arches, hyper and polyhydrosis, cogwheel rigidity such as in stroke, ALS, Guillain-Barré, MS, Parkinson's symptoms, seizures. Show you how to stop a seizure in progress. 15 seconds. We show you ways to keep it from coming back. It's all in part 1. This part 2, this, by the way, is not AK, reflexology, CRT, PNT, TBM, transverse friction massage, spinal reflex therapy, contact reflex analysis. It's not any of those. Okay? It's based on the known tenets of acupuncture, trigger point therapy, reflexes, and neurology. It's found in the Laws and Tenets in Dorland's Illustrated Medical Dictionary, 25th edition, Chusets Neurophysiology, Guyton's Textbook of Medical Physiology, and others, taught in all CCE accredited chiropractic colleges. And these are verifiable by standard orthopedic neurologic examination. I'm published in JMPT, Chiropractic Economics, on techniques being taught. I'm a former adjunct faculty member, postgraduate division, Texas Chiropractic College. Now, those were reflexes and light scar tissue in the skin. Thus, part 2, film 2, is dense scar tissue outside the joints. But the first part of it is actually continuation of 1. We didn't have enough time to finish that out. And the first thing we teach is how to test over 200 muscles easily in less than 10 minutes. Immediately strengthen all the weak ones by that touch that we've been talking about tonight, just like that. Lightly touch one single muscle, bang. immediately everything comes strong. The only exception is if you have extreme atrophy in a muscle, it'll take longer to come along. But most everything is immediately strong. Find dermatomal pain in less than 5 minutes. You palpate the whole body. Pain to pressure, in other words, trigger points, and immediately decrease or eliminate all pain, with the exception inflamed areas. Even those inflamed areas will normally drop by half immediately and just take a little bit longer to go away by lightly touching one single spot. And by the way, the spots that you touch are not the weak muscles. They are not the painful areas. Okay? If you think you've seen it all, think again. This all fulfills the evidence-based medicine and best practices. Here are some of the things that we teach in there. How to take care of chronic athletic injuries, which spill over into normal life too. Hamstring, ankle, wrist, golfer's elbow, tennis elbow, rotator cuff, knee, turf toe, shin splints, chondromalacia patella, weak ankles, trick knees, etc. Plantar fasciitis, myalgia paresthetica, bronchitis and asthma, gagging, esophageal spasm, reflux esophagitis, TMJ syndrome, migraine headaches, chronic whiplash, chronic hip, knee, and ankle, shoulder, elbow, and wrist pain, tendonitis, bursitis, adhesive capsulitis, frozen shoulder, Dupuytren's contracture, trigger finger, Osgood-Schlatters disease, chronic fever, sore throat, scar tissue and acupuncture, old fractures, chronic pain, bone sclerotome pain, fibromyalgia, burning pain, resistant sciatica, spondylolisthesis, necessity of using a cane or walker again, small joint fibrous ankylosis, chronic shingles pain, arthritic finger and toe joints, unadhere organs from each other, stimulate circulation, lymphatic flow, diaphragmatic and accessory breathing muscle function, endonasal techniques. We show you 4 of them. Eustachian tube techniques, about 4 or 5. Female cyclical menstrual pain, vaginal prolapse, dizziness and vertigo, dropped arches in the feet, no matter which one they are, unexplained chest pain, MS, Parkinson's, ALS, Guillain-Barré symptoms, ankylosing spondylitis symptoms, seizures, herniated or bulging disc, rotator cuff, frozen shoulder, foot drop, hearing loss, differing frequencies, tinnitus, all the tunnel syndromes. Again, this is not based and not at all having anything to do with transverse friction massage, AK, ART, Graston, any of those things. This is totally unique. And it's based on known tenets of acupuncture, trigger point therapy, etc., etc. Now, in this seminar also, we teach you how to reduce the rehab time to about 1/4 of what it normally takes. That's the middle part of the seminar. And toward the end, we show you how to take care of those dense scar tissue deposits normally in just one visit. Now, ART, right in their seminar, says takes 4 to 6 visits to free a muscle up of scar tissue. Graston, 6 to 10. Transverse friction massage, right in Cyriac's manual, says 10 to 20 visits. We seldom take more than 1 visit to free up scar tissue. So this, and it takes seconds. It doesn't take minutes. You don't end up at the end of the day just totally exhausted like you do with those other techniques. You end up refreshed, a lot less expense to the patient, a lot less pain to the patient, a lot easier on you. So this is something you need to do. Now, because that takes care of dense scar tissue outside the joint, the film 3 takes care of dense scar tissue inside the joint. Adjusting, manipulation, mobilization of extremity, cranial, and vertebra. Now, I've taken care of over 40,000 patients from all 50 states, 97 countries, over 3,000 top-level athletes, over 800 of which were professional athletes, taking care of 12 professional athletic teams, 3 of them foreign national teams. I was the first chiropractor invited to treat athletes at the NFL Run for Daylight and Fastest Man competition. Now, you can get most athletes back on the field in days in most cases. cases, even if they're off for months. And this spills over into regular practice. This is not just for athletes. Now, the first thing that we teach you here is how to get rid of the compensatory subluxations. Takes maybe 15 or 20 seconds to find the place to adjust, and the way you adjust it is just like that. Right before you adjust it, you palpate all the way up and down the paraspinal musculature. You feel the tension and pain, and the patient acknowledges it. You wait about 10 seconds after you do that, and you immediately go down there, and the pain and tension is gone. And that's a jaw-dropping response. And I urge you to do that one of the first things on every patient, because they immediately feel the difference, and it's a big change immediately. Now you're left to look at the primary subluxations for, let's say, the cavitation adjustments. But we teach you how to use a lot less force than you ever thought to do these adjustments. For example, we show you how to adjust the ribs and costal cartilages, golfer and tennis elbow, chondromalacia patella, bunions, dementias. Yeah, dementias. We show you how to do an adjustment on the knee and get someone back in their right mind and talking normally. And it's just astounding, because usually it's just seconds. And their face flushes because circulation immediately starts going back into the brain. High arches, flat feet, drop transverse cuboid arches, dropped arches, period. Reliably relieve reflex esophagitis, esophageal spasm, upper GI conditions, hiatal hernia. Yeah, this is an osseous adjustment to correct reflex esophagitis and hiatal hernia reliably. We have people go right to a meal right afterwards. They can't believe they're not refluxing at or during the meal and at night when they lay down. And this is not adjusting the stomach down like they do in applied kinesiology. That's adjusting an effect. We're talking about taking care of the cause, and we get into why. Acromio and sternoclavicular joints, chondritis and costochondritis, hallux rigidus, hammer and claw toes, bow legs, knock knees, frozen shoulder adhesive capsulitis, rotator cuff, all the tunnel syndromes. Cranial techniques. Now, the whole sequence takes about 3 minutes to do. We show you how to set it up and how to do it. It's very light force. And I've gotten autistic children speaking sentences after they don't speak at all, squeak instead of speak. They speak single words, and they start speaking sentences and then paragraphs. They go back to school with normal kids. If you've ever been around autistic children or adults, they are very angry all the time. We get that anger to go away because we're actually taking pressure off the brain. And I'm the only chiropractor in the state of Texas, second largest state and second largest amount of chiropractors that's on the recommended doctor list for treating autistic children for the state. And it's because we get these changes. Now, just to give you an example, doctor went home. He said, "I totally doubted you." He called me back. He said, "I couldn't believe it. This 5-year-old had never spoken a word. I did your 3-minute procedure on him." He turned around, looked up, and said, "Thank you, doctor." His parents couldn't believe it. I couldn't believe it. They started crying. I started crying. This is this doctor talking. A couple of weeks later, I got a call from another doctor, a kid who never talked, started talking immediately afterwards. And this stuff works, folks. It just works. Stop elusive migraines, improve vision, hearing, tinnitus, improve elusive organ, gland dysfunctions. You will learn right where those things come from and why this works. Correct TMJ dysfunctions. And we get into all of it. Now, these first 3 techniques take care of the nervous system, which, as you just saw in the seminar today, controls the secretory and excretory events of the body. Okay? And you're going to start noticing that people who have not been responsive to your nutritional interventions just clear up by themselves because it was actually a neurologic issue. And when you start doing these parts 1, 2, and 3, you're going to find that you need a whole lot less nutritional intervention because a huge amount of it is the nervous system. Remember, the nervous system is supreme. Now, based on that, part 4 deals with biochemistry and nutrition. And we get into things a lot of others don't. I'm going to say probably none of them do a lot of these. And one of the first things we do is we go through each of the nutrients. And we say, okay, this nutrient is found in these foods. And we ask, do you think anybody is lacking it going in their mouth unless they're eating totally junk food? And everybody says, no, there's no way. Then we do the next one, the next one, the next one. So the conclusion has to be that it's a metabolism of the nutrient then, the vitamin, the mineral, whatever. And so therefore, it goes in the mouth, but it has to be digested properly, absorbed properly, transported properly, absorbed into the cell, absorbed into the mitochondrial or nuclear membrane, broken down to its last constituent, then secreted or excreted. So it has to go through all of those. Then we go through the normal process of nutrients. And we talk about negative feedback loop, of which all living things need. So we show you in no uncertain terms that you may have to intervene 2 or 3 steps before or 2 or 3 steps after where the given symptom occurs. And I'd like to give this example. If you're having trouble with electrolytes, we're taught to give people electrolytes. We're basically taught to give people something for the symptom, right, where the symptom occurs. But what controls electrolytes? Well, it's androgens. What controls androgens? Progesterone. Progesterone also controls cortisone, which controls swelling and pain. Okay? What controls progesterone? Pregnenolone, which also controls DHEA. Now, DHEA and progesterone control testosterone production. So, for example, we show you how you get somebody with low or zero T back to normal T in maybe 3 weeks. It's very easy. And you don't have to give them the precursors of it. Testosterone controls estrogen. Estrogen in a negative feedback loop controls pregnenolone, like we talked about before. Now, pregnenolone is also controlled by vitamin D3, which is controlled by cholesterol and sunlight. So you see this whole thing in the negative feedback loop. So we go through all these sorts of things because we want you to really understand what controls what and where to ask a few questions, look at maybe a couple of lab tests and know what to do and get very, very quick results. And we show you before and afters in our lab results to show you what you can do. And it's quite astounding how quick it occurs. So we get into all sorts of symptoms, such as autoimmune diseases. You really don't really know what immune disorders are from biochemically, and we show you how to do that. People who are allergic to virtually every food feel they can't eat anything. We get to where they can tolerate about anything again. Dysmenorrhea, excess and prolonged flow, bone mineralization, osteopenia, osteoporosis, and fracture, how to speed the healing in those. We show you before and afters on those. Infection, natural antibiotics, nutritional interference with antibiotics, endogenous poisons and metabolic intermediates, hormone imbalances, seizures, ulcers, bleeding ulcers, constant bloody noses, how to take care of them. Fungal and candida conditions, take care of candida, 2-3 weeks maximum. Not difficult. Chronic fatigue, psychometabolic, psychometabolosomatic and viscerosomatic syndromes. Nutrient interdependencies, how one nutrient can correct 5 others, for example. Deficiency correction, long-term versus short-term catch-up. Lack of ingestion or a bioavailability issue. How to correct thyroid, non-thyroid issues, thyroid issues, carb and protein weight loss relapse. We show you the real causes for why people are having trouble with weight loss, and that's a big, big thing. I'll talk about that in just a minute here. Abnormal cell growth, malnutrition, preventing chemotherapy, tumor attenuation. Talk about all the reasons for cancer. Accelerate good cell growth, decelerate bad cell growth. Nutritional causes and corrections, behavioral disorders, hyper and hypotension, bone demineralization, depression, hyperthyroidism, hyper and hypoglycemia, failure to digest, absorb, metabolize, secrete, and excrete, acid-base imbalances, and that's not what you think either. A lot of other things. So we cover a whole big gamut here because we really want you to understand nutrition and all these other things. So I'd suggest if you can, that you order these films and start looking at them. It's really going to help your patients. Now, the next thing I'd like to talk about is mentoring. I do mentoring, and if you don't have the practice of your dream, you might want to think about undergoing mentoring. I don't know where my chat box went here. Maybe it's behind everything. Yep, there it is. I don't know how that happened. At any rate, I had the largest practice in the Midwest, and then I had the largest practice in the world. And when most practices went down by 30 to 50% after 911, mine went up 1,700% and stayed there for years. And I averaged for several years 640 new patient phone calls every single month. I didn't say every year, every month. For most people, that'd be a lot for a year. And there's no reason why you can't have the practice of your dreams, and I can help you get there. Just got to want to do it. Here's testimonials. Dr. Bonebrakes' Preeminence mentoring program, what I've been searching for my entire career. It's top notch. This fellow is from Minnesota. Dr. B's mentoring program is second to none. Wealth of knowledge, wealth of expertise. He's from California. Best investment I've ever made. I thought I was a good doctor before. And this doctor's from Cleveland, Ohio. Since mentorship with Dr. Bonebrake, I've seen several improvements in my practice. Patients getting desired results. He's been mentoring him and these others for several years now. He's initially from Chicago, developed his practice where he wanted it to go. Said, I want to go where I've never been before. My family wants to move to Florida, so he's starting out with a bang in Florida. I wasn't sure if I needed a mentor, as I already thought my business was very successful. Attended Dr. Bonebrake's scar tissue seminar where I witnessed immediate change myself and my brother. Observed others with both subjective and objective improvements in a very short period of time. He's from the Houston area, has one of the largest practices in the world already. We improved his bottom line by 160% in a year and a half. So it was, you can do stuff even with those large practices. You can do it with the small practices. If you're starting from zero, we all started from zero. We can take you there. I can't believe how much my practice has changed and grown since I began mentoring with Dr. Bonebrake. He's in Fort Worth. I've been in private practice 23 years. I own and operate a successful sports clinic in Austin, Texas. Gilbert Danforth, Lubbock, Texas. Really loves what we've done for him. I've been a sole practitioner for 25 years. Seen my fair share of seminars, consultants, and etc. Nobody like him. He's in the area down there in Houston also. Folks, if you want to improve your practice, the best time to start is right now. If anything can be said about me, I don't know how good I am otherwise, but basically I don't wait. If I want to do something, I get started and I go for it. If anything can be said about me, I just don't wait on anybody. I'm an action person. And if you want the practice of your dreams, you have to be an action person. You just got to go for it. You can't keep waiting. Preeminence mentoring, everyone is a good fit. Enables you to become top level. We want to show you rapid, efficient patient response with scientific methodology found in medical literature. become a nerve and biochemistry expert. That's where we want to take you. We want you to be able to hear the patient's symptoms, make a ask a couple of questions, get right to it, and make a jaw-dropping response every time. We want anything in your office to go that way, whether it's with associates, writing contracts with them, anybody that's hired with you. If you want help testifying in court, writing final narrative reports, how to file insurance, I can show you all that stuff. Get referrals from everywhere, get paid what you're worth, low stress and better family time. Others have committed, now it's your turn. You have to jump for your turn. Just close your eyes and imagine the business of your dreams, smooth running, plenty of highly satisfied and enthusiastic patients, just as many as you want. Financial security, time to enjoy with your family, time to exercise regularly, great health. 3 reasons Preeminence mentoring works for you. You will devote effort, time, and dedication to get what you want. Charisma is not necessary. I don't have any of that. Just ask my wife. I speak monotone. She doesn't know how people stay awake in my classes. I am not David Singer. That guy can sell anything to anybody with his charisma. I teach how to get results. I teach how to be short and quick in talking with people. You don't have to have that charisma factor at all. We show you how to do it right. Group and one-on-one mentoring is very affordable. Your next step is to commit to be superlative. Go to the link ttapcenter.com, choose a mentoring level that fits you, and commit to change your life. Now, there's 3 types of mentoring. 12-month group mentoring. It's a 1 group call per week, an hour each time for 12 months. $500 a month or 1 payment of $5,000 saves $1,000. And you'll receive 52 1-hour weekly real-time group interactive podcasts. Type in any question you want, listen to questions that others ask and how I respond to them. You ask your questions, ask absolutely anything about your practice. I want you to step up your practice to the level you want and desire. Up your income dramatically in accordance with your level of commitment. Get paid for what you do, okay? How could anybody want anything different? Think and reason quickly. Give talks that give lots of new patients. I averaged 220 every mall show that I did without advertising any of them. I averaged 220 new patient visits out of each one that I did. When I did just in office or I went to any other place to give a talk to lay people, I averaged 35 to 50 new patients every time I got a talk. Don't ask patients for referrals and get scads of them. We'll show you how to do that. Communicate in such a way as to draw referrals to you from all over. How to testify in court and depositions. There is an art to it. I show you that. How to write narrative reports in the best manner possible. Situations answered that solve your own situation. If you want to go to the 1-year one-on-one in the first 3 months, you get those benefits as well, but you have to commit. 6-month one-on-one mentoring. 1 call per week for 26 weeks, 6 months. It's $1,000 a month or 1 payment of $4,000. You save $2,000. So it's 1 hour directly with me for 26 weeks. Anything in your practice. Now, I do this differently. I don't try to make your practice what mine has been. I ask you, what do you want to do? You tell me what your goals are, and I say, okay, this is how we're going to get you there. And we want to go where you want to go, okay? I don't do some of what I call stupid things that other practice consulting and practice management and practice coaching do. They try to make you into something they want you to be. I want to know what you want to be, and then I say, okay, if that's where you want to go, this is how we get there, okay? I show you the path. If you decide to step up to the 1-year one-on-one mentorship in the first 3 months, you'll get its benefits. Now, in the 12-month one-on-one, you get 52 1-hour calls. It's $1,000 a month or 1 payment of $8,000, which saves $4,000. That's quite a savings. Prepaid also and get you all 4 of those films for a year's viewing that we just went over. I'm going to be making a link for websites. I have thousands of doctor and patient testimonials. And basically, there's going to be one for each part. And people will be able to go on and see something categorized in alphabetical order. And people will go on there and say, okay, you can say, well, I took this part, this T-TAPS 1, 2, 3, or 4. Now there's about to be a fifth one I've started teaching. And they'll look on there and say, wow, these other doctors, these patients are getting excellent results. You took that seminar I need to come into for it. So it's not just you saying it, it's them seeing that others did it. Now I did this on my own website, and I averaged 20 very new patients per month, never been in before, per part. And I sent to my own patients, and I said, go on and look at these things. And I got 20 re-ups from established patients saying, I didn't know you could take care of all this. I need to come in. I have other stuff I need you to work on. So it was good for essentially 160 new patients every month just by putting these links up on the website. Them seeing the effects that it had on patients and the effects other doctors were getting. And even if you don't sign up for the mentorship, you can still get that for $50 a month per course or per link. Very much worth it. Doctor Blog, $50 for each part. Here you can discuss with other doctors, hey, I'm having a problem with this, what would you do? And they throw in their 2 cents and you interact. And a good thing about this is they'll tell you what they used with T-TAPS, and they'll also tell you some stuff they used outside of T-TAPS. So you get more than T-TAPS on it. T-TAPS is good, and if you want me to, anybody wants me to kick in, what would you do, Dr. B? Then I'd kick in what I would do on it also. You get anything that you want for any of part of your practice in here, okay? You also get 12 seminars, and we're going to be putting the CEs for online, or you can get them in person. So you'll have, once we go online with them, you can get them online, or you can get them in person for CEs. 12 of them, so that's included. And I'll cover what's on top of your radar first. You'll get a certificate of completion for each T-TAPS part that you get through and do well in. And if you decide to do another year, it'll be just half the price. And virtually everybody who's taken the first year, they want that second year for half price because they improved so much with the first one. Now, what do you have to do? You got to commit now to achieve your dream practice. Business results depend on effort and following directions. I can't do it for you, but I can show you what to do to get there. You have to lose your excuses, take consistent action to improve. If you'll do this, sign up. If not, please don't sign up because you're not going to get anywhere. It's going to be a waste of money. We give you the information and encouragement, but you're the one that has to take action and improve your life. Okay? Now, we're back here, and before we shut it off for the day, does anyone have any questions relative to anything today for what we talked about in the main lecture? If you want to ask anything about the films, if you want to ask anything about mentoring, please put it in the talk box here. We went about 4 minutes over. I apologize. But now's the time to ask questions. Does anybody have any type of questions? Any questions whatsoever? Okay, thank you, Dr. Esquerdo, also. Okay, well, we're going to cut it off then, and make sure you make the next class. And we put out the next row of seminars that are coming out. Part 3's coming around in Texas starting weekend after this one. And any questions you have whatsoever to help, you need help with patients, this isn't just people taking the mentorship. You know, I'm here to help you and help your patients, okay? Dr. Mahavir, thank you, Doctor, for all the information. You're welcome. Thank you for your comment there. All right. You all have a wonderful day, and wonderful weekend. We'll see you in probably about 2 weeks for the next one that we do. Look out for that. It's going to be on a Monday or Tuesday. Thank you so much. Bye-bye.